Hello， 他可能是一个一个进来的，我不知道他用的是哪个。
Hello， 有听到吗？
有。你现在是不是你的账号名是什么？
我用的是 Gabriel Live。
可以先让 Gabriel Live Tech 进去吗？我改一下我的名字。
等一下，
现在还有谁是在排队进来的？让他们要不先进来吧。
我想要先让那个要演讲的医师进来，因为这样我才能知道谁是谁。
因为我现在看不到说他们的账号名，或者你截个图给我看，我看哪些人在排队。
好。
他们想把医生先放进来，这样确保知道哪个是医生。他有很多医生嘛，然后他可能这样子方便一些，就知道前面几个。
Gabriel 先进是不是？
他们都100人是吧？
对，他们那里是，等一下，哦，我还没有收到截图，等一下。但卡尔呢？你打个电话再给卡尔。好 ，Gabriel 你进来了。你在申请是吗？你进来了是吧 ？OK。
那个进那个也要让他们进。
好。
婉宁，我传给你了。
OK，我看一眼，我看一眼，等一下哈。
所以这是他们
对，
嗯，前面那位是医生诶。T user CMK5，哎，看不出来哪个是 Kevin， 这个肯定不是。CMFU 是谁？
那个王主科。
看不出来。
可是我这边改好像人家看不到。
哦，七位，你那边那个名
目前看不到那个 Kevin Walsh 哎，目前看不。
对啊，我这里看也没有。这里好像都是台湾的医生了，剩下。
你们要不先把台湾医生放进来，不然他们以为这个都没有连接上，因为马上也要整点了。先放进来，
到时候
这样对啊，教授也要进来。进来之后比较好辨认哪个位医生，然后到时候可以调一下顺序吗？
不用。
你电脑有举手是吗？你电脑有在哪里？
没关系啊，你不用改了，真的。
有举手功能是吧？
对，上去点。
哦，那你们截一个图，截一个图出来，我发给他们。
是德国的医生吗？还是
谁
Warren Cromhan 还是
？Warren 不是，是我们泰国的医生 Dr. Warren。嗯。哎，那天测试的时候他还
不知道谁是谁，怎么办？
你们都先放进来吧，不然医生以为进不来呢。
先把我们声音关掉。
都没关系啊，发到哪个群都 OK。哦，我要转过去。好。哎，卡尔呢？
我改成王医生。
马上就要开始了 ，Kevin Walsh 有没有上线呢？
德国医生。
对啊。啊。哦，王教授。Hello，王教授，嗨。Hello。
您都好吧？
都还好，就大家现在都是戴口罩上班。我看一下，我找。
截图镜。哎，你看得到我吗？哎，哇，看到徐仲豪、黄建富、婉玲、Gabriel， 阿泰。
目前因为他们都是全体精英，所以可能他们
OK， 我知道。
对。
老师还有我。
哎呦，王建南。
哎，老师好，哎，真高兴看到老师。
还有谁？他再来。
喝点开碗。
我去找一下他。等一下。哦，我先。
这个原刊等于中间。
看点医生。
我在脸上。你去电影那里。
没有练。对啊。你镜头有开吗？
没有，我不想开镜头。
不要开镜头。
Kevin Walsh 来了。对。
Kevin 进来了啊，对 ，Kevin 进来了。
我这个已经连了吗？
让 Kevin 把摄像头开一下呗。
Hey, Professor Icon, Gabriel speaking.
Yeah. So now we're online, and also Dr. Kevin Wash also there, and all these physicians are there. So are you able to connect it to it? Yeah.
How do I change the background?
So, Kevin,
Hi, Cuckoo.
yeah,
Correct.
hear me?
Oh, really?
Can you hear me?
Do you have any problem with that? The link?
Is the camera on? It's not
Yeah,
on.
sure.
这样子
No, right now it's not blocking.
OK
But you have to on your
Oh yeah, the meeting ID is 948-025 48025.
we can record reaction chat.
So you can look at the reaction. You wanna mute?
Right.
Yeah, so this is the camera.
Right.
And that's
Can hear me or what?
你就日升静音，然后会对
OK，我先静音一下。
啊，你已经开声音了。
OK，
自己开声音，听出去我们关掉。
可以了哈。
那等一下问一下他们。
And I'm ready to deliver my lecture at 2:30, right?
Yes. Yeah. So, Dr.
Hi,
Icon.
Cuckoo.
Yes. Good day.
Okay. So I should say good night, good evening, because we now in Taiwan it's about 8:10
In the evening.
Yeah. How's everything in Germany?
Fantastic weather, but crisis mode.
Oh yes. So Kevin, how about that in Ireland?
It's similar to what Andreas said, that the weather's really quite good, which helps, but we're still in lockdown with no decision by the government as to when to release us from lockdown. So it might be, it might be just after the May bank holiday, early May, that they'll start to resume, business activities. At the moment, we're mainly just busy in the children's hospital.
Oh yeah.
In the adult hospital, we're doing less because there's less sort of adult congenital heart emergencies. Most are fairly elective, and the adult hospital is very busy with COVID anyway.
I heard that children are less infected in COVID.
Yeah, we haven't seen much death in children and very little clinical cases.
Yeah.
So I think that's good. That's good for us and bad for old people.
Yeah. Also, Taiwan, that today there's no new diagnosed case is a good news, because the majority of the case are diagnosed we have very rare domestic case. So that's good news. So Professor Icon, can you start your presentation?
Sure.
So
This is my presentation. Can you see it?
not yet.
要看他的，
Data presentation.
他的话从他那边设置，这是我们的画面。
对，给的
哦，你要看说，
他的 presentation.
您要演讲他的吗？要由他那边做，对对对，要由他那边设定。就是一是等下演讲者他会直接开启他的页面，然后我们会直接看，对。
So are you ready to present your?
Sure. I'm sitting at the start slide.
Yeah.
Do you want me to deliver my lecture now?
Yes. So Kevin, it's okay. We started now.
No, that's fine. If Andreas wants to go ahead first, that's perfectly fine with me.
Okay.
Okay, I'm happy to do so. So obviously it's good evening for you in Taiwan. It's a good day for us in Munich. We have fantastic weather, but as I said before, our hospital is running in a crisis mode, and we have 4 patients on ECMO with COVID, and so we are really kind of scared of this disease, but I'm sure you know this disease better than we do because you have more experience with it, but we really take it serious. Anyway, it's not the topic of my talk. My topic of my talk is Ceraflex German Registry, Clinical Efficiency and Effectiveness of the Ceraflex ASD and PFO occluders. So the first ASD occlusion was published in 1974. Something wrong?
So I cannot see your slide.
Okay. What can I do?
So just upload your slide. I saw your slide before, but now it didn't show on my computer.
Andreas, if you share your screen, then we probably can see it.
If I share the screen,
Yeah, if you hit the share screen button.
Okay, I will. How about this?
Yeah, I can see you, but I cannot see the slide.
I'm sorry.
All right.
Maybe now?
Yes. Yeah, it's quite clear. So maybe you can start your presentation.
Okay, this is my first slide. Can you see it?
Yeah, quite clear.
Okay, this is just the first publication on ASD occlusion published in 1974 by King and Mills. And recently in 2003, 4 patients were still alive of the 5 treated patients. All of them had complete ASD occlusion. It was a 23 Frenchies that was necessary to implant this device. Balloon sizing was developed. Why is this always coming? I always hear a bell.
Yeah, but because of the someone signed in.
Okay. It was a huge piece necessary to implant this device, and balloon sizing was developed because no echocardiography was available at that time. Although successful, only 5 patients were treated with this original device. So the indication for treatment, we all know symptomatic patients or hemodynamically significant shunt QP to QS more of 1.5 to 1, right ventricular enlargement, or if there is paradoxal septal movement, patients with a small ASD, PFO, and a history of paradoxal embolism resulting in either stroke, TIA, or peripheral embolism. So there are several forms of ASDs. You know that we can close a foramen ovale, we can close holes that are in the fossa ovalis, we cannot close septum primum defects. There is now newer reports that you may be able to treat patients with sinus venosus defect with the combination of covered stents, but we have not done that yet. And sometimes it's possible to close a coronary sinus defect, but in most times not. So mostly we're talking about these defects in the septum. And here you see an anatomic picture of a typical ASD, which is kind of round shaped. Now, it was Jürgen Hörer who looked at our surgical results between 1974 and 2000 adults. He looked at a total of 281 adults. Mortality was 0.7%. And what was interesting, that 88% of the patients had some kind of complication. So even though it is standard, and some people may call it gold standard, the complication rate is higher than what we see after interventional closure. So I'm talking about the Ceraflex ASD occluder. You see him here, how it comes packed. It's a transcatheter preloaded device with a flexible attachment. I really like this attachment. There's no hub on the left side, and there's a special coating which should prevent the release of nickel. It's a relatively comfortable system. You screw it together, you flush it, and you can use it. So here comes the sizes in the waist between 6 and 32 millimeters. The disc sizes are larger, of course, as it's always, and here's the French sizes of the sheaths that are necessary. The sheath sizes are a little bigger than what we know of the Amplatzer. The echo criteria for an ASD closure for an ideal patient is if it's centrally located, if the native size is between 15 and 15 millimeters plus 14 millimeters septum length, and if there's enough rim. In our clinic, since Peter joined us some 8 years ago, we try to close the ASD just with echo. Now, this is our experience in Munich. You see here, we started in 1996 with the angel wings. And if you look at the year 2018, we used a lot of Ceraflex. At that time, we were doing the study. We used Occlutech. We used few Amplatzers and some Gore septal occluders at that time. So this is our total experience. You see, we've been treating 1,790 patients, of whom 1,144 were ASDs and 646 were PFOs. Lately, with the 3 studies coming up, we are quite running up with PFO closure. And you see, we used 206 Ceraflex, PFO, and ASD occluders lately. So I'm coming to the Ceraflex experience we have in Munich. The smallest patient was 8 months. The defect was 5 to 6 millimeters, 6 kilo patients, and the largest defect patient was 62 years old, 86 kilos, and balloon sizing was 29 millimeters. So here is a typical, this is the largest patient you saw. There's deficient aortic rim. You see the typical color flow mode, and there was no aortic rim for more than 45 degrees. You see here the whole native, it was 18, but we came to 29 millimeters with a balloon test. So now you see how we do it. We, under TE guidance, we place the long sheath into the pulmonary vein. Then we place the occluder, we test for stability. And what is also very nice about the Ceraflex, if you let go of it, it doesn't change the position. Here in this picture, you see the big occluder, 32 millimeter occluder positioned, and the cable is removed and it doesn't change position. We really like that. What we also like, because it's flexible, it doesn't tilt through the aorta, and this flexible device helps us to position the occluder if there's deficient aortic rim. So we really like the occluder for that also. We participated in 2 studies. One was the LifeTech Ceraflex post-market surveillance study. I think, Kevin, you also participated in that one. Dublin is also one red dot.
Yes, we did, yes.
So that was Dublin, Paris, Zurich, Milano, Munich, Leipzig, and Berlin. So I'm talking about that first. Here you see it was a total of 120 patients that were enrolled. You see the centers that enrolled patients, 6 sites, 55 ASDs, 47 PFOs, and 18 docs were closed in 6 sites. And the German study, we were more or less setting it up between Leipzig, Munich, and Freiburg. And since there's no data yet available for me for the international study, I will talk more about this because I have more data on that. So inclusion criteria is as always, exclusion criteria also is as always. I will not talk so much about that. We did a screening, then we did the intervention, then we did the echo at discharge, and we did a 6-month follow-up examination, which was just a regular clinical examination with echo. You see that 143 patients were screened and 43 were not treated for several reasons. So a total of 100 patients were scheduled for the intervention. Median age was 24 years, more or less, from 3 to 80. Median weight was 44 kilos from 13 to 120. And gender was more females than males. And defect size was between 4 and 30 millimeters in diameter. Here you see we had 36% superior position, 11% anterior position, 46, most of them central, some posterior ones, and some inferior ones. How was device selection done? With a balloon stop floor in 74%, with a waist in 15%, native measurements in 8%, and angiographic measurement was done in 2 cases. So procedural time you see here was median 41 minutes, 15 to 228. Exclusively TOE-based closure was done in nearly 70% of the patients. If radiation was used, the time was short, 0.9 minutes, and 96% a single device was used. 3 patients needed a second device. There was nearly no residual shunt in the patient, just a small one. And 98%, there was no change of the device position after release. Here you see the occluder sizes that we used. You see mostly the 12 millimeter and 8 and 18 millimeter were used most frequently. So we're coming to complications. Minor vascular complication was 6. Air embolism that was seen in ST elevation was 2. And we had 2 device embolizations. You see how 1 device is taken out here. Now, if device embolization occurs, and here you see it's not a Ceraflex, it's an Occlutech that happened to me, it may be a problem to get it out. You see that this device is in the aorta, and to get out an Occlutech is quite challenging. In this case, we were able to put in a long sheath and bend the long sheath with a stiff wire, and we could connect it with the biotome, and so it was able, we were able to take out this embolized device really nicely. But some other day, it happened to us that we had an Occlutech device that was 28 millimeters, and we could not retrieve it, even though it was possible to snare it. And so we sent the patient, had to send the patient for surgery. So on the bench, we tried how to get out this occluder. Here you see an Occlutech 10 millimeter, it's no problem. But if you take a device that is larger than 26, you can't get it out, not even through an 18 French sheath. And so we scheduled animals, an animal test, and we were very happy that we have the Maslanka snare there for the big devices. Here you see our animal test, and this is a Ceraflex that is embolized in the pig. It was a pig. And we could easily get it out here with a snare, but this was a 16 millimeter device. So it was possible to get the 16 out. So 10 and 16 we could get out easily with a snare. But if you take big devices, and you see here a very big device, 40 millimeter Occlutech device, we used a snare to fix it, and then we used the maslanka really to get it out, because this will never go out if you don't have the maslanka or a really strong grip. So follow-up data from our patients are available now in 69 patients, you see here. So we don't have the full follow-up yet, but the long-term results are really nice. So I may conclude that ASD closure with a Ceraflex device is possible, safe, and effective. The device adapts well to all atrial structures during deployment. It's easy to handle. Success rate is really nice. Nearly no angle change after release. And so far, I said there's no device embolization, but there was 2 that embolized. There was no thrombus formation during follow-up. And if you want to remove big umbrellas, the maslanka bioton is very helpful. And Stanimir published this in the Cardiology in the Young in 2018. So thank you very much.
Thank you. Thank you, Professor Icon. So I would like to ask the audience, any question?
Andreas?
Yes.
Kevin, yes.
Kevin, yeah. I enjoyed your presentation very much, and the paper you wrote on the retrieval with some animal experimentation is very useful, because these non-screw devices are potentially a big problem when they migrate in comparison to an old-fashioned device which has a screw on it. So when you catch the device initially with a snare, where do you and then you come up with the maslanka, where do you actually where do you actually put the maslanka on? Which part of the device do you put the maslanka forceps onto?
Excellent question, Kevin. First, I think you need maslanka only in the big umbrellas. So the question is, of course, where is the umbrella? So if we lose the umbrella in the right atrium, and it's a real big one, it will not go through the tricuspid valve. It will hopefully stay in the right atrium. But still, first thing, of course, what you have to do, you have to fix it somehow. So however you can do that, I mean, if you use a multipurpose catheter or anything, just to fix it, and then so it doesn't go away. So then you need a second catheter usually. Depends on, probably I would go for a pretty big sheath, 14 millimeter short or long sheath to have a big sheath. And through this, I could fix the embolized umbrella somewhere in the right atrium. And then I would try to snare the pin to fix it. And then I would use I would draw the umbrella close to the big sheath. I would prefer a 14 French sheath. And then I would take the maslanka gripping next to the hub. So I can pull. If you look at my presentation, they were close together. If you see that,
yes, I can see that. Yeah.
And we had it close together. So in the central field, this works best.
Yeah. Okay. Now that's good conceptually, and the fact that you're pulling on with 2 things means it's probably going to orientate better into the sheath.
Correct.
As you slenderize it.
Correct, because if you get caught on the tip of the sheath, of course there's some people who say you should cut it, or maybe so it gets better in. But doing this, it's centralized, and it was possible in the animals to get even very big umbrellas out.
Excellent. I think very important. So probably probably important for anyone who's doing these cases to have availability of Maslanka forceps in your laboratory, to have a couple of them available.
Well, actually, Kevin, yesterday we used it on a stent that was in the aorta, and we were about to lose it. And the Maslanka was also very helpful because it gives you a very stable possibility to not that it doesn't fly away. So we also used it yesterday. We used it and had a good result finally.
Great, amazing.
So Andreas Joko Wang from Taiwan, I have a question. You have at least 3 kinds of the device in your lab, right?
Well, we have consignment of Ceraflex, of Occlutech, and of traditional Amplatzer.
So how you
These we have as consignments.
So how you choose them, make a choice?
Well, actually, I like these flexible devices, so I like Ceraflex and Occlutech best.
Okay. So have you heard any erosion of the from the Occlutech or from the Ceraflex?
Well, erosion, we have, as I said, 1,700 cases, and we have 1 case of erosion of which we know of. I think the dark number could be bigger because the patient may die and I may not know it. Mm-hmm. So we have 1 patient of erosion, and there was an Amplatzer, 26. It occurred after 8 months. Mm-hmm. I asked the Occlutech people if, because our Occlutech experience is lower than Amplatzer. We have hundreds of Amplatzer devices. Occlutech, we have no erosion, but I asked Occlutech people and they said there is few erosions with Occlutech as well. With LifeTech, I do not know. I asked the LifeTech company people and they couldn't tell me up to now.
Thanks. Could you tell us what's the rate of erosion from the LifeTech device? Lens? So
I haven't heard an answer to that either. I know Alan Frace wrote up, I think at the last, I think it was PICS in San Diego. He had a poster with 7 Occlutech erosions that he managed to get people to send it. But I think any wire-based mesh device must have the potential for erosion. Although along with Andreas, the softer devices are certainly more reassuring. You know, and I think the shape of the Ceraflex discs looks like it would be less likely to erode than, say, an Amplatzer. But who knows, until you have big databases and thousands of implants, you might not detect a signal.
I absolutely agree with Kevin. Just if you touch and if you compress a Ceraflex or an Amplatzer, especially the ones bigger than 26, they are definitely softer. A Ceraflex is definitely softer.
So any heart block cases with Ceraflex?
Any what cases? Sorry, I didn't understand.
Heart block.
Heart block.
Heart block, no. But I mean, in our series, we don't have a permanent heart block at all.
Okay.
Yeah, but we have it after surgery. Yeah. We have by now we have 2,000 surgical ASD closures and maybe 1 or 2 heart blocks we have.
Yes. Okay.
It's certainly possible. We've seen it with both Amplatzer and Occlutech. We've seen transient AV blocks related to usually big devices in small patients, often with trisomy 21.
Okay, I can only say we've never had a heart block in a patient and we had to, secondarily remove the device. Certainly not. But of course, we see sometimes conductance disturbances during the intervention. We see that.
Yeah.
Okay, thank you, Professor Icon. So
It's a great opportunity, and I really enjoy this. Thank you very much.
thank you. So, so Kevin, you will give the next talk.
Okay, thank you. I'll see if I can do that. Okay. Yeah. I'm just trying to share my screen. Sorry. Just 1 second. Is that okay now? Can you see the screen?
I haven't. Your slide did not show on the screen.
I'm not sure. Okay. Let me just check that again. Share screen again. Yeah, here. Okay. See if this will.
Okay.
Is that appearing on? Is that appearing on the screen now?
Okay.
Okay. I'll make that bigger. Okay. So that's the. I don't want to be, too repetitious, as Andreas has given a really good explanation about the whole device, but you can see the evolution of the LifeTech devices from the HeartR to the Cera, which had this titanium nitride coating, to the Ceraflex with the special attachment system. There you can see a close-up of it. With this essentially a double back suture, which has a mandrel that's able to slide backwards and forwards in the delivery cable. We saw a lot of the advantages. The titanium nitride coating is meant to prevent nickel leaching, which would improve endothelialization. Although I think there was a paper comparing the inflammatory markers between Oclatec, Amplatzer, and Ceraflex, which didn't really show any difference in things like VEGF and other other pro-inflammatory markers. And the other thing is the braided structure in the device means that the left atrial disc is flatter, which may be an adaptation. But I think one of the things is, and we'll see maybe a little more in detail. We saw the delivery system. It has the advantage that it has no screw and you don't have to screw it on, so it's straight out of the box, and it comes with its own loader, and you can use whichever sheath you prefer. We sometimes use it with the Cook check flow sheaths rather than the Steries, because it's sort of quite independent. You don't need to open a delivery system with its sheath. Here's the mechanism of how the actual Steries works. Here you can see on the handle, you have the little red button, which you don't touch until you're ready to release, and then the blue button which releases the suture. And you can see, just if we let the cartoon run again, you can see how it works. As you pull back on the blue, you pull back this mandrel that's holding the suture in place. Okay, and here's, I think, maybe the biggest difference. I think if you can get a side profile of the device, you can see that it doesn't have the discs aren't clamped together as much. I think that's probably what makes it easier in terms of when you're dealing with a deficient aortic rim, because the discs are a little more separate. Then it doesn't prolapse through the aortic rim deficiency as much as, say, an Amplatzer would. And we'll see some examples of that. Felix Berger gave me some of his nice videos. So the Germans have done lots of work with this. And here's examples of the flexibility and stability tests on the Steries. You can see it's good and strong and flexible. We went through the dimensions previously with Andreas. And there's also a multi-fenestrated or cribriform version of it, which goes up to 40 millimeters. This is a cartoon of how what happens with the Amplatzer device. And we're all very familiar with this action, and it sort of became part of daily practice to, you know, the echocardiographer to wonder about the discs and attachment, often having to retract on the right atrial disc so that you can see the tissue that's caught in the device, and then seeing this, you know, sudden movement as you unscrew from the device. So we've got used to that. In terms of publication, it's still as a device relatively light on publications. You know, and there really isn't that much literature on it. Obviously, when we write up the Ceraflex multi-center study, the European post-market surveillance, then we'll have significantly more devices published. But this was one published in Hearts in 2015, 125 patients, Ceraflex 58 versus Amplatzer 67, similar patient characteristics, really good results, 100% occlusion rate in both groups. In one Amplatzer, there was some transient left atrial hub thrombus, but there was no migration, strokes, or thromboembolism in any of the patients. Here they have the picture of how Ceraflex doesn't change angle when you release it. This was another study. Here they combined both Cera and Ceraflex with, and they said the usefulness of the flexible rotation feature. They had 201 patients, ASD, PFO. In 7 children, they didn't do because either multiple defects or the septal length was too short, or they had a leak with 38mm balloon testing. The occluder was removed prior to release in 11 patients, and a successful implant in 183 patients. Follow-up of 1.8 plus or minus 1.7 years. No residual shunt in all of them after 3 months. 2 transient pericardial effusions and 5 transient SVTs in adults. No deaths, embolization or major complications. Unsuccessful in 11 patients, 5.7%, in all of which the occluder was removed prior to release. The cause of failure was unstable position during push-pull, significant residual shunt after deployment in 3 patients whose basic atrium wasn't big enough to use a larger occluder. And there were 3 cases where the device obstructed either the coronary sinus, right upper pulmonary vein, or superior vena cava. And you can see in the picture, there was one device with a conical malformation. This was a 22mm Ceraflex. So they obviously took that out easily and put in a 24mm instead. Felix very kindly gave me some of his information early on, and also some slides of device deployments. This is an example of a 10-year-old, 33-kilo secundum ASD with right ventricular volume overload. You can see there's a very prominent eustachian valve there. A native diameter was 8mm and stop flow was 11mm. Put in a 12mm Amplatzer septal occluder, and this is the check prior to release. And this was what it looked like prior to release, and after release, you can see the major alteration, which the cartoon showed earlier. And there, that's what it looks like. We're used to that. It's a good result. We're very happy with that. We're used to the release. This is another case, 15 kilos, secundum ASD, RV volume overload, native 9mm, a small aortic rim, and a small superior rim. Balloon sizing, stop flow 11mm, so not a big defect. Amplatzer septal occluder, and here you can see this prolapse that we're really familiar with, where it comes through at the aortic end when that's deficient. And we've also learned that if you implant like that, although you can release it, it will have migrated by the morning. Second attempt, same thing happens. Third attempt, even with trying to open the right atrial disc, similar, you can see it's still prolapsing. And then what to do next, your problem solving. Well, you could use the Hausdorff lock sheath. You could use a second catheter or dilator or balloon assisted technique. You deploy in the pulmonary vein. I guess for us, we would usually just go straight to the right upper pulmonary vein and use a roof technique, or use a larger device. But so instead they switched to Ceraflex 12 millimeter ASD device, and you can see the device does have very different edges when you look at it echocardiographically. You can see it's much more of a H-type effect here with rounded, blunted edges. I think that's probably what helps it to actually not to come through the defect, and also means it's softer in terms of avoiding erosion. And there you can see the effects. And that's just after one attempt, and it's dealt with the aortic problem nicely. And this is, and there you can see the difference in shape. In reality, it actually has a very different shape to the Amplatzer septal occluder, which you actually see better on fluoroscopy than you do when you're examining the device in your hands. And that's it released. And follow-up echo. Another case with a small rim towards the atrial roof. This an older man, 26 years, 56 kilos. Sized at 27 millimeters and a 28 millimeter Ceraflex. Orientating very nicely. And that's after release. Another example, a bigger man, 102 kilos, with a floppy posterior inferior rim and missing the anterosuperior rim. Stop flow balloon sizing 21 millimeters. 22 millimeter Ceraflex. Prior to release, and really very little change with release. And that's what it looks like on 3D. Nice and flat. So the German Heart Center, this was September 15, so this was a while ago. These were the numbers they'd done, 14 patients, so small numbers. In terms of Dublin to the similar stage, and since then we've done a fair few more. There were 78 patients between May 14 and December 15, and this was it was Children's Hospital, so this was the range. Mostly secundum ASD, a few atrial fenestrations. That was device size versus weight. So you can see the most common sizes. TOE size, balloon sizing. And results, complete closure 70, small residual, device migration in 1. I think that patient, went to surgery then. I don't think we had the Maslanka, or at least we didn't try. Trivial residual. And this is taken from your paper, Andreas, showing a very nice paper. This was to me was the most interesting aspect of it in terms of the Maslanka forceps. This was a device deliberately embolized in an animal in the right ventricle. And what you needed to do it, going straight with the Maslanka didn't work. You needed to go with an ordinary biopsy forceps or snare to stabilize and pull back the device, and then catch it with the Maslanka as the final strong pull into the sheath. So that's an important thing to have if you're using devices with small hubs. There was a concern early on, and I think it was that you could have a tulip malformation in much the same way as we had cobra malformations. And in fact, when we started the LifeTech study, we had to stop it for a while because of device availability, because they were concerned that there could be this tulip malformation. But the reality is that tulip was related to probably device oversizing in the defect. So to conclude, our early medium-term experience with Ceraflex is very promising. There's high occlusion rate. It's a flat configuration, flexible implantation characteristics, very little position change. I think it's a big advantage in the deficient aortic rim. You have to do less of these pulmonary vein maneuvers. It has the disadvantage of needing a larger sheath, 1 to 2 French. There really aren't huge amount of publications of it. Hopefully that will change. And in terms of erosion and endothelialization, we've already talked about that. We're not certain about that. Hopefully it will be very little. So thank you very much for listening.
Thank you, Kevin, for your nice presentation. Because of our experience very limited regarding Ceraflex, so do you have any opinion of the larger sheath requirement because of this really a big problem for the small children? So can you comment about that?
Yeah, it hasn't really been, because the vein is such a stretchy structure, it hasn't been a real problem, but you are a couple of French's sizer with, say, like if you were bigger, if you're going to put in a 10 millimeter Ceraflex, you're going to need a bigger sheath than if you were to use a Amplatzer septal occluder. So we certainly still stock Amplatzer septal occluders, and we have tended to use them in some of the very small infants. If we had, say, like a 5 or 6 kilo infant, we would probably consider using the Amplatzer one, because you could deliver a device up to 10 millimeters or up to 9 millimeters easily through a 6 French torque view, and you might need a bigger sheath with the Ceraflex. But that would be the only thing. It's not a huge issue. So once you get to 10, 12 kilos, then I think it's probably much less of a concern.
Okay, thank you. So thank you very much. So we would like to perceive our experience about the Ceraflex device in the complex ASD case. Xi医师, Dr. Xi, can you?
I'm here.
Okay. So can you present your slides now?
Yeah, of course. Let me try to do it. Can you see my slide?
Yes.
Okay. So I just start from here. Okay. Good evening, good day, everyone. It's my great honor to be here to present our recent very limited case of ASD occluder with Ceraflex. And this is a 32-year-old lady, and she presented with a 3-month history of exertional dyspnea, malaise, and palpitation. She was known to have ASD since her childhood, but she was lost to follow-up because of asymptomatic. And we can see the blood pressure was about 111, and the saturation on room air was about 95. On physical examination, we can hear the irregular heartbeat. She had a loud grade 3 diastolic murmur over her left upper sternal border and the lower sternal border, probably comes from her severe pulmonary regurgitation. And the chest X-ray showed dilated cardiac chamber and engorged pulmonary vessel. The ECG showed right axis deviation and the sinus reason. This is her transthoracic echo, and we can see from the right upper here, and the right ventricle is quite dilated. And here we can see the severe pulmonary regurgitation. And here we can see the severe tricuspid, the severe pulmonary hypertension. The measured maximal pressure gradient of the TR was 89. We did the transesophageal echo, which showed the very large ASD. And we can see there is a membrane-like septum, deviated septum, beside her ASD hole. On 3D, we can see the ASD defect is here, and there is a deviated membrane-like septum, then followed by a strand, a cord-like structure. The defect size is quite large. We measure it with multiple plane measurement. You can see here the size was measured about 2.2 by 3.1 centimeter. On 3D echo measurement, the defect was measured about 2.1 by 3.9 centimeter, which is quite large. On color Doppler, we can see the flow was bidirectional, and the here's the left to right and right to left. However, when we do some more plan, we can see that here is the ASD, and here was the I mentioned deviated septum with a cord, and here the color red color was the right upper pulmonary vein drainage here. So we before our procedure, we were worried that the occluder could be deviated by this membrane and the strand. So before our procedure, we did a MRI to make sure all the pulmonary veins return into left atrium, which the MRI confirmed that. And we also did CT imaging. Our radiologist did a lot of analysis for us, and we can see the size here. They measured the diameter was about 33 millimeter by 25 millimeter. And also the structure here, we can see the right lower part, we can see the deviated membrane, which was almost riding on the pulmonary vein. So here's our plan. We plan to do the ASD occluder in our hybrid room, and under general anesthesia and the TEE by cardiologist. We did right side cut first and did some O2 saturation measurement. We plan to do ASD occluder first from her right femoral vein. And if we failed or any complication, our surgical team would take over. And here is her right heart cuff data. As we can see, the obvious O2 step up from the right atrium. The measured pulmonary artery pressure was quite high, which is 92 over 40. The QPQS was calculated to be 1.2, which was compatible with her bidirectional shunt. So about the occluder procedure, I think Professor Wang would take over the presentation.
Okay, thank you, Dr. Shi. So you want to present some echo?
Okay, I would proceed. Before the ASD occluder, we did balloon sizing. And as we can see, there's a waist, and on the angiogram, which was measured to be about 22 millimeter. However, on the intraoperative TEE, we can see here in the center is the balloon, and the high flow here was the pulmonary vein return. And we can see the waist probably comes from the deviated membrane and the strand, not on the defect atrial septum. So we decided to redo our measurement. So we can see we decided to measure the lower part of the balloon, which was about 29 millimeter. So we decided to choose a 32 millimeter Ceraflex occluder device.
Okay, any TE images? Can you show?
Okay, yeah. The our first attempt to deploy the occluder, we can see here the from this by cable view, we can see that the occluder was overriding the deviated septum and the cord, which make the occluder obstructed the right upper pulmonary vein. And at this time, her blood pressure dropped a little from about 100 to about 80. We can see here on the 3D TEE, Here is the occluder at the atrium, and here was her deviated septum and strand. The disc was overriding on the deviated septum membrane. So now we have our occluder like this, and the pulmonary vein was occluded. So we decided to do our second attempt. So Professor Wang, should I proceed?
Okay, so sure, go ahead.
Okay.
Oh, okay. So sorry. Let me take over your presentation.
Okay.
I'll stop for a while. Okay. So actually, this is very complicated cases because you can see this in the strand also incomplete form of cold triatum. Okay, good. Yeah. Okay. So because the pulmonary pressure is very high, and so I do a wedge angio, and the wedge angio show the loss of the ablation, and also some capillary phase did not show very good. So I think even I want to close the defect, I should have some fenestration on the device. And this you can see that it's very complicated. You can see a membrane like this, and also interatrial strand here. So these very complicated cases. So we do some balloon sizing, the initial balloon sizing here, but I think the balloon is stuck by the membrane in the left atrium. So I put the balloon a little bit lower down. So this is the rear, the defect here. So the sizing is 27.8. So this is initial sizing here, but actually this is the correct position for the defect. And this is the first few, we have 3 attempts, and the 2 attempts failed because we were stuck by the interatrial strand. And you can see that we make the fenestration here. And you see that they do some gap.
Chuku,
yes.
Chuku, did when you say you made a fenestration in the device as well?
Yes, because of the patient, the PA pressure very high. I think the PVRI should be more than 8.
And how did you make the fenestration?
I stuck with a needle and take the patches, cut the patches, then took it out. So you'll see our fenestration later on. So I deployed the device. Finally, this is maybe the 3rd or 4th attempt, because the first few attempts was caught by the strand and also limited by the cold triatum membrane. So this is the final result. But still, you can see the strand here. Okay. So you can see the fenestration here. The fenestration about like 6 or 7 millimeter. So this is before I detach. Okay, you can see no movement at all, right? So really, I didn't quite understand the anatomy of this case. So this after deployment, you can see the memory here. But actually the upper chamber and lower chamber communication still very good. We cannot see any flow acceleration. So Dr. Shi.
Yes.
So you can, the final, you can
okay.
Then the final.
Okay, I would show her final results here. And here is her final TEE. And as Dr. Professor Wang said, there is a fenestration here. And we can see clearly that the occluder did not obstruct the pulmonary vein flow. And here is still some gap between the occluder and the aorta. But the struct was quite stable. And we can still see the strength here. This is the thoracic echo several days after her procedure. We can see the pulmonary pressure is still quite high, and the post-operative medication was as shown. We gave her dual antiplatelet, and we gave her sildenafil, and we plan to add on bosentan in the future. And this is our case, and this is our team. I want to thank Professor Wang for his kind instruction of our procedure.
Thank you, Dr. Shi. So I would like to make a few comments about the Ceraflex device, because I think I like this device very well, because I have some two cases before in my lab. This is my another case. Is 15 millimeter defect. Because I rarely do balloon sizing, so I just measure the largest diameter. So I use 18 millimeter device. You can see how it's really fast. You just deploy the waste, then the right disc come out, and there's no any jump. So that's my comment. Because of the alignment of the ball stick with edge receptor is very good. There's no jump after detachment. And so I think this is an ideal device for closure of ASD with various kind of morphology. I think the success rate would be better than other devices. So I think this device is a good device for beginners, because I think the alignment is so good, so you don't have to adjust any position of the device. You just deploy the depth disc, then near the defect, you just deploy the waste, then you come out quickly and without any jump. So I think this is my favorite device. But the only limitation is much more size, only 32. And we need a bigger sheath. So that's my comment on this device. Thank you very much. So if any question, you can send your to our KS question to KS.
Juku, that was very nice. The patient you did, has she felt a symptomatic improvement from having the defect closed?
Dr. Shi now follow up this patient.
Yeah, I think this patient had minimal symptom before the procedure. So after that, I asked her, and she felt everything is quite good and almost the same. But I think further adjustment of her medication should be needed, and I would do more follow up.
Yeah, I mean, she had spectacularly large pulmonary arteries. They were really very big. You'd wonder whether at some point, when you finish the aspirin and Plavix medication, whether you'd end up on warfarin or something in her case. It would seem to me as if she would eventually, I suppose when ventricular function deteriorates, which it will of course, that she would be a good, certainly prone to in situ pulmonary artery thrombosis. I mean, she has some washing at the moment from the pulmonary regurgitation, but I mean, even the CT scan showed spectacularly large pulmonary arteries.
I think at that time I will back stent in the fenestration. Stent. Yeah. Do you agree?
A stent would be, it probably gives you a more a larger fenestration, but the atrial septal anatomy also created a fenestration. I think that strand that you had on the septum, which was part of a potential quarter atriatum, seems to allows you to create a fenestration anyway.
Yes.
Which may be in her interest. And I mean, for that sort of case, we'd be even inclined just to leave alone or treat with bosentan or macitentan and sildenafil, or maybe just even leave alone if the patient's entirely asymptomatic at the time, because I would think the pulmonary vascular disease probably isn't going to regress, is it?
Because she's not so old, so I think
yeah,
we'll have the chance. But
because of age,
maybe we should give them more stronger vasodilators such as bosentan as soon as possible, because I also worry about the pulmonary pressure may remain very high.
Yeah, most likely.
Okay. So can I speak to my 请大家若有意见的可以或是给 KS 主持人或举手安排发问。I asked the question.
Hello, Professor Wang.
Yes.
I'm Jana Wang from Tainan. Thank you for your excellent case. Yeah, I would like to ask about the question about the fenestration. Do you think how is a similar way to make the fenestration in this kind of device and occlutech device and unprocessed device? Do you use other or some different way or some technique?
No, that's the similar way.
Okay. So when will you consider to put a stent on this case, the atrial stent?
I think maybe 6 months later, if the pulmonary pressure remains high, put a stent in because I worry about if the defect closed, and the pulmonary pressure remains high, then the nature of history will be changed to idiopathic pulmonary hypertension. That will be worse than leave it alone. So I think I make a fenestration, stent fenestration 6 months later.
Okay, thank you. Yeah, thank you.
Kevin, I would like to know your opinion about the stenting of the fenestration.
I think just a formula, maybe a formula type stent, you could just use off the shelf and just create a diabolo by using the sheath, so that you flare the distal end in the left atrium, and only when you've got the flare do you actually pull back against the ASD device, and then unflare, but try to leave, maybe make the aim for 6 or 8 millimeters for the fenestration. But I think you could use just an ordinary off-the-shelf Formula 35 type stent, or you could go to the trouble of making your own with you know, a Diabolo type 1 with a Powerflex balloon and putting a pacing wire on it. But then you're using an 11 or 12 French sheath to deliver it. So I think the fact you actually have a device there, so you've got a good landing zone for the stent, and you've got you know, you've got a good your radiographic landmark as well by having the device there. I think you could go for a relatively simple implant. But I would think, you know, using the long sheath, whatever sheath you're using, destination sheath or whatever, you know, using that halfway along the stent to create a distal flare, and then pulling back a little bit, I think is going to produce a nicer result, and not completely overinflating.
Okay, thank you.
And I think you could probably avoid, by that, you could avoid using a really long stent. Like if you use a 3 centimeter stent, it's really going to stick out both ends, and maybe there's a bit more thromboembolic risk, you know, because although you might, because of severe pulmonary hypertension, they recommend anticoagulation a lot less than they used to. Like it used to be like mandatory for all idiopathic pulmonary hypertension to go on warfarin. They don't recommend that anymore, but and if the function is quite good and the patient's asymptomatic, you might need it. But the more material you have, and particularly material poking into the left atrium, the more risk there is of some thromboembolism at some point. So having your stent, you know, not too proud in the atrium has got to be good.
Okay. Thank you. So, any other questions?
Now, I suppose the only thing would be for the LifeTech people who've organized this, that if they made the Ceraflex in bigger dimensions, even if we did have to use a bigger sheath, I think that would be a very good move. I think it would make a big difference. I don't know what the engineering constraints are. I know we like the Cera device. We used it in the bigger dimension as well, because that comes in a 42 millimeters, and that's useful for some patients with very big defects as well. So I think it is possible to do it. So that would be the thing I would advise most if they're able to make some bigger sizes.
Yeah, sometimes we have 40 millimeter defect like this case. But fortunately, I think the strength may be not the good thing, but for the, is the dimension 39. So, but I think the strength is there. I think I just close the larger defect. So leave the gap there. So I think the good thing for the very strength there is not bad.
Yeah. Yes, I agree. It helped. You could have even maybe forgone the fenestrating the device and just have said you'd probably have a leak left anyway.
Yeah. Right. So any other questions?
Hi, Prof. Hi, I'm MC from Malaysia. I saw in the series you have 2 cases of Ceraflex device embolization. Did you snare them or do you take it out surgically? If you snare them, is it more difficult compared to the usual unpluxer? Because looking at the eye is much smaller than the unpluxer or the Ceraflex devices.
Yeah, I think for at least our migrations that we've had with Ceraflex, I think we've done surgery for them rather than use the Maslanka. But Andreas has good experience. I think it's animals in terms of the retrievals for the Ceraflex, and it's humans for the Occlutech, if I'm right.
我不知道，因为他们刚刚都有问到 fenestration 的事。OK， 好拜。
Andreas, have you retrieved the Ceraflex with the Maslanka?
Well,
outside of the animal.
Am I on? Can you hear me? Yes. In our series, there was 2 embolizations, and actually both of them were not in Munich. They were treated in other hospitals, and both of them were treated surgically. We didn't have any embolization with Ceraflex occluder in those studies. But as I said before, and as we only had in the animal, we only had 10 and 16, and both were, it was possible easily to take them out with a snap. The problem, as you said, Kevin, that we had while we did the animal study was that we couldn't retrieve a 28 Occlutech occluder. We didn't have big Ceraflex devices available for our animal study, so I cannot comment if it is possible to retrieve a big Ceraflex into a sheath.
So,
of course, it's always better not to have to retrieve.
yeah.
Especially at 6 o'clock in the evening.
Especially then, or Friday.
On Friday of a bank holiday weekend.
So any other
Well,
questions?
the surgeons have to have something to do.
They are our friends.
Yes, exactly.
Okay. So I would like to thank Kevin and Andreas and all the audience for this wonderful meeting. I think Ceraflex is a very good device, and also for all kind of morphologies of ASD, except the defect more than 32 millimeter. So I would like to close this meeting. So thank you, Kevin and Andrea. So,
thank you very much for the invitation.
Thank you. Thank you.
Thank you very much.
Thank you.
And all the best. And hopefully we'll all be over all of this very soon.
Okay, thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.